From Microbe TV, this is Infectious Disease Puscast, episode 43, recorded on December 7th, 2023. Hi everyone, I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. You are stuck with a solo show with me today. Daniel will be back for our next episode. Puscast is a review of the infectious disease literature for the last 2 weeks that I found interesting or entertaining. So on to the literature. To start off, we'll do our viral section. Please remember to check out This Week in Virology and Clinical Updates with Daniel. The first paper I have is from CID, Treatment for First Cytomegalovirus Infection Post-Hematopoietic Cell Transplant in the Aurora Trial, a multi-center, double-blind, randomized Phase 3 trial comparing maribavir and valganciclovir. The Phase 3 Aurora trial was designed to compare efficacy and safety of maribavir with Valgan for the first asymptomatic CMV infection following a stem cell transplant and was conducted over 97 centers. Patients were stratified and randomized to maribavir 400 milligrams BID or renally dosed valganciclovir for 8 weeks with 12 weeks of follow-up. There were 273 patients in the maribavir group and 274 in the valganciclovir group. The primary endpoint of confirmed CMV viremia clearance at week 8. So there's a primary hypothesis of a non-inferiority margin of 7%. This primary endpoint was not met. So maribavir, it was 69.6% and valganciclovir 77.4%, having an adjusted difference of 7.7%. The key secondary endpoint was achievement of CMV viremia clearance with no clinical findings of CMV tissue invasive disease at week 8. Maintained through week 16. At week 16, 52.7% treated with maribavir and 48.5% treated with valganciclovir achieved this. So that's an adjusted difference of 4.4%. Treatment-related adverse events were more common in the valganciclovir group than maribavir, 61% versus 54%, with neutropenia occurring in 53% of patients receiving valganciclovir and 16% receiving maribavir. Not surprisingly, discontinuations were mostly due to neutropenia. For the maribavir group, that was 4%, and valganciclovir, 17.5%. So, although the non-inferiority of maribavir to valganciclovir for the primary endpoint was not achieved based on the non-inferiority margin, maribavir did demonstrate comparable CMV viremia clearance during the treatment follow-up with fewer discontinuations for neutropenia. So I am interested to see what people think about this trial. Does this cause you some concern or hesitation for using maribavir as a first-line CMV treatment in our stem cell transplant patients? I think another important note is that the primary endpoint not being met in the maribavir group was partially attributed to development of resistance during the 8-week treatment phase. So compared with valganciclovir, more patients receiving maribavir developed treatment-emergent mutations during treatment and did not achieve the primary endpoint. And as a reminder, CMV strains that are resistant to maribavir usually remain susceptible to valganciclovir and ganciclovir, but it is possible to have cross resistance. The next paper I have in the viral section is from MMWR, Mortality Among Children Aged Less than 5 Living with HIV Who Are Receiving Antiretroviral Treatment, U.S. President's Emergency Plan for AIDS Relief, 28 Supported Countries and Regions, October 2020 to September 2022. This report, it just gives us some insight into the global mortality among children living with HIV under the age of 5, which is not particularly well described. This information or data is from PEPFAR. Among children receiving ART, 4.9% of those aged under a year and 2.5% of those aged 1 to 4 years of age were reported to have died annually. So in comparison, these numbers And older patients were 0.5% for the 5 to 14-year-old group, 0.7% for the 15 to 49-year-old group, and 1.4% for the greater than 50 age group. The proportions of reported deaths among infants under a year were 4 to 9 times more than those in the older age groups. Interruptions in treatment were also more common among children under 5, so it is possible that the mortality is also disproportionately underreported in this age group, given there are more patients lost to follow-up or having interrupted treatment that might have died. I have one quick one from Daniel. The article, Boostability After Single Visit Pre-Exposure Prophylaxis with Rabies Vaccine, a Randomized Controlled Non-Inferiority Trial. This was published in the Lancet Infectious Disease. This was a randomized controlled multi-center non-inferiority trial. They had healthy adult travelers who were randomly assigned to receive a single visit intramuscular, a single visit intradermal, or standard 2-visit intramuscular. So these are all pre-exposure prophylaxis. Or the last group here, no rabies vaccination. 6 months later, participants received simulated intramuscular rabies post-exposure prophylaxis, so day 0 and day 3. The rabies virus neutralizing antibody concentrations were measured repeatedly, and they found that the single visit intramuscular rabies pre-exposure prophylaxis induced an amnestic antibody response non-inferior compared to the 2-visit intramuscular schedule, whereas the single visit intradermal PrEP did not. The fold increases in the single visit intramuscular and single visit intradermal schedule were 2.32 and 1.11 times as high as the fold increase in the standard schedule, respectively. All right, I will move us into bacterial. For this, please be sure to listen to This Week in Microbiology. Another big update in circulation, update of cardiovascular implantable electronic device infection, CIED, and their prevention, diagnosis, and management, a scientific statement from the American Heart Association. So there have been several important papers that have been published since the last statement. The last one was in 2010, and some of those newer trials were PADIT, Prevention of Arrhythmia Device Infection Trial, and RAPID, Worldwide Randomized Antibiotic Envelope Infection Prevention Trial. And then, of course, there are some other studies investigating TE and PET, so these all have been incorporated. I think one of the nice things about these new guidelines is they have some really wonderful graphics. I would say the key one is Figure 3, which is their updated diagnosis and management algorithm. I thought that instead of sort of walking through everything, I just would pull out a few areas that there's been some variation in the recommendations amongst guidelines like AHA, HRS, EHRA. Sorry, a lot of alphabet soup today. The first one is duration of antibiotics for those with a lead vegetation or bloodstream infection. So a lot of these look pretty similar. If you have evidence of pocket site erosion without purulence, they recommend 7 days after extraction of the device. A pocket site infection with purulence, 10 days after extraction. And then bloodstream infections are sort of something longer than that. Valvular endocarditis, we continue to treat as endocarditis with a 4 to 6 week course. And then they do have a brief comment about POET trial in there. For reimplantation guidance and timing after the device extraction, this new guidance really aligns with what is in the EHRA and HRS guidance, so delaying until signs and symptoms of infection have resolved. And then in the text, it kind of says delaying 3 days of negative blood cultures seems reasonable, and then to delay up to 14 days if there's evidence of valvular endocarditis. Some other things to note, they did comment and put recommendations related to PET scan for possible pocket infection. They suggest this in patients with device implantation within 3 months before presentation with subtle inflammatory signs at the pocket site. And they suggested an approach of either a 5 to 10 day anti-staph antibiotic challenge versus early PET-CT for those who fail antibiotics. And then in those whose implantation is over 3 months from the development of clinical symptoms. All right, and then the last thing I pulled out, does TEE need to be done in all patients with pocket infection? Yes, if positive blood cultures and or prior antibiotic pretreatment. And they suggest you can defer if it's a pocket infection with negative blood cultures, although you may ultimately still want it as a surgical planning tool. So nice new updates. Check out the figures. In addition to that diagnosis management algorithm, figure 1, their central illustration is quite nice as well. Another new document or guideline is from SCCM and IDSA, guidelines for evaluating new fever in adult patients in the ICU. And so just to highlight a couple things from this, there are some recommendations on the measurement of body temperature, antipyretics. I love the reminder to not use antipyretics just because the patient has a fever. They provide an approach to imaging, so getting a chest x-ray and essentially all those with fever in the ICU, and then doing additional imaging based on other risk factors like surgery that may suggest you should get a CT. They do provide support for performing a PET-CT if the risk of transport is acceptable, with as sort of a weak recommendation, acknowledging very low quality evidence. There is a nice section on blood cultures, including the recommendations of simultaneous collection of CVC and PIC cultures, sampling at least 2 lumens of a line, and ensuring that any rapid molecular testing should have concurrent blood cultures. And maybe, I guess not most importantly, but quite importantly, for febrile ICU patients with pyuria and in whom a UTI is suspected, please replace the urinary catheter and obtain urine cultures from the newly placed catheter. So now when you discuss this, you can bring up this guidance. Lastly, there is a section on rapid biomarker testing, which is recommends procalcitonin and CRP in critically ill patients with new fever, no clear focus, and a low to intermediate probability of bacterial infection, but not using it in those who are deemed high risk. And then there's a nice list of non-ID causes of fever in ICU patients for reference. The next paper I pulled is from OFID, Risk Factors for Serogroup B Meningococcal Disease Among College Students. This is a study from the EIS program and CDC. There were 229 meningococcal disease cases reported in 2014 to 2017, about 3/4 of which were Men B. The authors found that Men B disease was 4-fold higher in undergrad students, 11.8-fold higher among first-year undergrad students, and 8.6-fold higher among residents, or non-undergraduate versus non-undergraduates. And I think what people have noticed and taken away is patients affiliated with Greek life had a 9.8-fold higher risk of disease compared to other students. And characteristics of colleges associated with sporadic cases, outbreaks, or both included public schools, large undergrad student bodies, large Greek life populations, and high party school rankings. So if you had a higher party school ranking, you were more likely to have a Men B case. If you want to find out your own party school ranking of you or your loved one, you actually can check out what they use. It's www.niche.com. So overall, it is a low incidence, but provides a signal of which college students may be at highest risk. So adolescents planning to live on campus at a 4-year college, particularly those planning to engage in Greek life or attend schools known for their social life, they may benefit more for vaccination. So very, very interesting. And, actually I think is a useful tool for when you're talking to these patients. All right. The article Comparison of Adjuvant Clindamycin versus Linezolid for Severe Invasive Group A Streptococcal Skin and Soft Tissue Infections was recently published in OFID. So these are the results of a retrospective single-center cohort study of patients with Group A strep isolated from blood and or tissue cultures with invasive soft tissue infection or necrotizing fasciitis. These patients underwent surgical debridement and received either linezolid or clindamycin for at least 48 hours. The primary outcome was percent change in the Sequential Organ Failure Assessment, or SOFA score, from baseline through 72 hours of hospitalization. They found there was no difference in the reduction of critical illness as measured by the SOFA score between baseline and 72 hours, comparing patients who were treated with clindamycin versus linezolid. There also was no significant difference found in clinical secondary outcomes like duration of pressors, number of days on the ventilator, length of stay in the ICU. And so the authors suggest that given its more favorable side effect profile, linezolid may be a viable option for the treatment of serious group A strep infections and should be further studied. I actually personally like linezolid a lot for this. So now this at this point, I think is the largest clinical study looking at this question. And then these next two, I just wanted to plug the CID state of the art reviews. They're really great. The two most recent ones are persistent enterococcal bacteremia, and then the other one was called Frameshift, focusing on harm reduction and shared decision making for people who use drugs hospitalized with infections. And they're just really wonderful, and they both, along with all of the state-of-the-art reviews, come with an infographic, which of course I always love. So definitely check those out. All right, I'll move us into fungal. I only have one paper today. This one's from Medical Mycology. The Billerud, hopefully I'm saying that right, mill blastomycosis outbreak, comparison to historical controls. You may remember there was a large outbreak of blastomycosis among paper mill workers in Michigan in February of this year, 2023. It ultimately involved 120 cases, 28 confirmed, 92 probable. This paper compared these 2023 outbreak cases with the Michigan disease surveillance system of prior cases. So there were 34 historical cases. Blasto incidence for the Upper Peninsula was 2.13 per 100,000 persons years, with counties bordering Wisconsin having higher incidence. In this setting, the outbreak cases, the patients were significantly younger, more likely to be male, had more respiratory symptoms, and a shorter time from onset of illness to diagnosis. This actually is the largest outbreak of blasto reported to date in North America, the first in an industrial facility, and the first to involve Blastomyces gilchristi specifically. So there was no specific source of infection in the mill that was identified. I thought this was interesting just to point out other outbreaks that have of blasto have been associated with soil excavation, construction, day campers visiting a beaver lodge, canoe trips, wood piles, and digging up prairie dog tunnels. All right, and then for parasitic, be sure to listen to This Week in Parasitism. I pulled a paper from The Lancet. Primaquine radical cure in patients with P. falciparum malaria in areas co-endemic for P. falciparum and P. vivax. Prima, P-R-I-M-A is the acronym for the study. A multi-center, open-label, superiority, randomized controlled trial. So, in areas co-endemic for vivax and falciparum, there is an increased risk of vivax parasitemia following falciparum malaria, and that is higher than expected from just the risk of reinfection alone. So the idea here is trying to opportunistically eradicate P. vivax hypnozoids from the liver in patients who present with uncomplicated falciparum malaria, and this is termed universal radical cure. Most countries recommend low-dose primaquine over 14 days. And this study attempted to assess the safety of high-dose, shorter course Primaquine, so 7 days, and whether universal radical cure reduced the risk of future P5X episodes. This was completed in clinics in Bangladesh, Indonesia, and Ethiopia. In Bangladesh and Indonesia, they included everyone except those under a year of age. In the Ethiopia group, they excluded really any children under the age of 18. And so these were patients with uncomplicated P. falciparum monoinfection with fever in the 48 hours before their visit to clinic, and that who had a normal G6PD. Patients received artemether-lumefantrine in Ethiopia and Bangladesh, and dihydroartemisinin piperacin in Indonesia. And then they were assigned to receive either high-dose, short-course oral Primaquine versus standard care. 495 patients were included in the intention to treat analysis, and the study found that high-dose, short-course Primaquine in patients with uncomplicated falciparum was safe, well-tolerated, and reduced the risk of subsequent P5X parasitemia within 63 days by 5-fold, so 11% versus 2.5%. I think the biggest thing is there was a lot of heterogeneity between the sites, and one example of that is that the risk of Vivax parasitemia during the follow-up period in standard care was pretty different in the 3 different countries. So 12.7% in Ethiopia, 17% in Bangladesh, and 2.2% in Indonesia. So I thought this was really interesting. I'm not sure I knew a lot about the approach to universal radical cure before, so I learned a lot from reading this paper. All right, and then I'm going to wrap us up with our miscellaneous section. In CID, microbiology, public health, and the murals of Diego Rivera. For those who don't know, Diego Rivera is a Mexican painter who has several frescoes in Mexico and the US, many of which have some depiction of infection or microbiology and some aspects of public health. And actually, this year when I went to Mexico City, I actually saw some of his work, so it wasn't too long ago. And this paper is so cool. It goes into the background of a few of Rivera's frescoes. And there's actually the images and the history, so you can look at them together. So I really encourage you to check out the paper and the images, which they got really nice high-quality ones, to point out the different examples that they were showing. So it's not totally understood where his knowledge of a lot of this microbiology and these details came from, but he was creating a lot of these works around the time when a lot of modern medical microbiology texts were coming out, and of course he likely interacted with a lot of doctors and medical elites in the setting of the care of his wife, which many of you probably know, but his wife was Frida Kahlo. So really cool paper and a combo of microbiology and history and art. So I just really loved it. All right. And that brings us to the end of this solo Puscast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcast and microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. Please send them to puscast@microbe.tv. And if you like what we do, please consider supporting the science shows of Microbe TV at www.microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com. And you can click on the donate button. I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.